these other things. So when people are acutely ill, there is a role for a short course of antibiotics, really based on how you define their exacerbation, whether they have a heavy burden of bacteria in the airway, and then what type of antibiotic to use. So most exacerbations are related to temperature, they're related to viral illnesses where antibiotics would help, but there are some that are related to bacteria where a short course of azithromycin or moxifloxacin will make a difference in your recovery. And that's for an acute exacerbation. The day you wake up and you have a low-grade fever, a worsening cough, and you just don't feel normal. That's fine. But now we're talking about chronic antibiotics for prophylaxis. So when this was first proposed years ago, more than 10 years ago, people said, oh, that would be bad, because then our patients will be immune to the antibiotics. But then it turns out, next slide, we've actually used this in many situations effectively. So we use it with autoimmune diseases, inflammatory lung diseases. We use it in bronchiolitis, which was a viral syndrome in Japan, where you put people on a low dose of antibiotics year-round. We use it in cystic fibrosis. It's been shown to reduce hospitalizations in that population. We do it with non-cystic fibrosis bronchiectasis. And we often do it in patients with chronic lung transplant, low-grade rejection, where daily antibiotics slows the rejection of the lung. So we have evidence in other diseases that daily antibiotics may make a difference. So in my practice, we started doing it around 2008 in patients with bronchiectasis, in patients with bronchiolitis, and in patients who were, quote, frequent exacerbators, that phenotype where they get sick more than 2 or 3 times a year. That was demonstrated in a large study in Denver, Colorado in 2011. We looked at over 1,000 patients. Some of them got antibiotics year-round. Some of them just got antibiotics when the doctor thought they needed it. And then at the end of the year, it turned out the ones who stayed on antibiotics had fewer exacerbations. They had greater improvement in their quality of life, and improvement not just in the frequency of exacerbations, but the time in between exacerbations. In this group, there was no documented resistance to the antibiotics, and really no negative effects, some minor things that were reported. Antibiotics may affect heart rhythm, they may affect hearing. There are things that chronic antibiotics do. Next slide. Next slide. It's stuck. Now, Russell asked me to mention a few things about this. There are some situations where surgery offers advantages over medical care, but they're few and far between. So if you have giant cysts of the lung, something called a bullite, it's often congenital, not smoking related. Removing the bullite preserves lung function. And we've been sending patients on that since I've been in training. You have the volume reduction surgery, which in carefully selected patients improves survival, improves oxygen requirement, improves 6-minute walk. You have lung transplantation, which will do the same, but it's, again, fairly limited in its scope. And then we have the research aspects of it, bronchoscopic volume reduction surgery. What if we can get the same benefit of surgery without having to open the chest? Patients would heal faster and still have the benefit. So it's considered a potential alternative. This is purely research at this point. It's for emphysema, not bronchitis. As a matter of fact, patients with chronic bronchitis did poorly in these studies. And there are all sorts of things that they use. There are valves, coils, stents. There's even an aerosol that they use. I was involved in some of the studies 10 years ago using valves. Dr. Shepard at VCU is involved with a study now. I'm going to show you a picture of what he's doing. So this will have a role for patients with pure emphysema who would be a candidate for surgery but may not want surgery because of the risk. Next slide. So now in the big picture, how do we look at things? you have medications, smoking cessation, chronic antibiotics, eucalyptics, rehab, oxygen, advanced planning for your preferences and goals of care, and then in a limited number of patients, you have surgery. Now this is the study that Dr. Shepard's doing called the Approved Trial. They're taking tiny little valves that look like fishing lures, very expensive fishing lures, and they're putting it in the airways that are leading to the part of the lung that doesn't work. And these little devices block air from going in. They allow mucus to come out. So it doesn't drown the lung, but it allows the lung to collapse slowly over time. We were involved in a similar study using a different device. These studies are very compelling. So what that means is I'm hedging. I'm not telling you it's a thumbs up. I'm not saying it's a thumb down. The preliminary data is very interesting in that in carefully selected patients, there were a lot of benefits. But that's why we're doing the research. So theirs is called the Approved Trial, sponsored by Spiration and Sal. If you guys have the desire for more information, I can email the link to us. Next slide. So what are our new paradigms? My goal is to prevent disease. How do I prevent that? I counsel all of my patients about tobacco use. If they're a smoker, I encourage them to quit. If they're a non-smoker, I congratulate them and tell them not to stop. If we can reduce the environmental impact, smoking and smog and other pollutants in our lungs, we can minimize lung disease. I'm a huge advocate for screening for lung disease. I don't really believe doing what my children do makes sense, running around with your ears covered, pretending that the noise doesn't exist. If I have a patient with lung disease, I want to know soon so I can make changes in their therapy. I'm also very fast at doing advanced screening, not just looking for emphysema and chronic bronchitis, but you now know that CT screening has some advantages in the early identification of lung cancer. So we have lots of reasons to screen patients now with advanced imaging. And I'm interested in the biomarker work that they're doing locally and away, because I do think eventually we're going to have a marker for lung disease the way that we have a marker for prostate cancer and a marker for rheumatoid disease and all these other things. My next goal is early treatment of the disease. So we know that frequent exacerbations has associated with it high morbidity, high mortality. You get sicker and you don't live as long. So what I want to do is identify patients early, then prevent the exacerbations. Prevention is treatment. And then, if there are frequent exacerbators, I want to bring in additional resource, better treatment of the disease to reduce disability or death. We've all seen it in our friends, we've seen it in our family members, some of you have seen it in yourself. To go from being able to less able is a hard thing to live with. So what I want to do is to see when patients are beginning to go down that slope, and then I pull in resource. Sometimes it's just adaptive equipment. Some of you are already in motorized scooters. If it helps you get out and about, let's do it. Some of you need different types of oxygen, portable oxygen units, so you can travel better. These small portable concentrators. If it gets you out and about, let's do it. So I look at what we can do if you're beginning to develop disability from the illness, what we can do to mitigate it. Early initiation of rehab. I really encourage rehab, both structured rehab locally and rehab at home. I tell my patients I want them to do something for 20 minutes every day other than eat or watch TV. And I'm trying to do that myself because you know what? I don't appreciate when my doctor preaches to me. And my doctor's Dr. Morris. He's a very young, thick guy. You have to admit he looks great. I realized that I don't look as well as I used to. And my daughter once asked me, when I look in the mirror, what do I see? And I told her I see a full head of hair, I see eyes that aren't tired, I see a face that's not wrinkled. And she grabbed my hand and said, Papa, you need to look in the mirror more closely. So now I'm resorting to something else. I'm telling everyone I'm 76 years old, and they go, wow, you look great for your age. And that's working right now. But I like to get patients into rehab because our level of fitness at whatever age we are determines our level of health 10 years later. So my wife and I are going for evening walks now. It's actually been very good for the marriage and it's been good for my health. I have many patients on antibiotic prophylaxis, really based on the phenotype of their disease. If they have chronic productive sputum, and if they have more than 2 exacerbations a year, this makes a difference. I bring in adaptive equipment, ramps in the home, stairs, railing, whatever it takes to keep you safe and active, that's our goal. And I also bring up palliative symptoms, and you may have noticed that I'm very open. My patients seem to understand. When I meet with them the first time, I tell them, when I look relaxed, you should be relaxed. When I look concerned, you should be concerned. When there are things we need to talk about, we need to talk about. No barriers, no hurdles. There comes a time with every patient that I need to establish what their goals are. Do they want to live longer? Do they want to live better? What are their goals? So I'm very aggressive about advanced planning and estate planning and end-of-life planning. So the summary. Many of you have COPD. I can tell you it's not one disease. It's a systemic disease. It affects the lungs, certainly, but it affects the heart. It affects our circulation. It affects our muscles. It affects our bones. It affects our spirit. We can use the phenotypes to really dictate what therapy is best, not for all patients, but for the individual patient in the office. And that the future of COPD is really going to be based on these new guidelines and some scientific advances that are coming around. And with that, I'm going to stop.
Wow.